This is Diego Ruiz Dasilva, a dermatologist at Forefront Dermatology in Virginia Beach and also an assistant professor at the Eastern Virginia Medical School. And I want to talk to you guys today about spesolimab for generalized pustular psoriasis. IL-36 blockade, it was kind of a long-term time coming, even though this is a very rare condition. We don't necessarily see walking into the office all the time. I used to see more of it when I was in the inpatient setting, working in a tertiary care hospital at Penn. But I think it still remains one of the most severe diseases that we can take care of in dermatology, something that comes with morbidity and mortality, with sepsis physiology, and these patients are doing quite poorly, where we didn't have a very effective treatment or something that was designed to treat this condition, right? We know IL-36 is highly upregulated in this pustular subtype, and now we have an agent that can block that and treat these patients. I think in my experience, what's been difficult sometimes is that you really want rapid control too. If you look in the literature, right, off-label or just case report and case series, you can see pretty much all of our advanced systemics for psoriasis being used at one time or another for GPP, but with kind of variable success and variable speed in terms of onset. A lot of combining with cyclosporin or even systemic steroids, which is controversial because that can be a trigger for GPP flares as well. And so now we have something where in monotherapy it is officially studied in this population with great efficacy. Originated as a acute GPP flare where they get an IV infusion over 90 minutes, and essentially that could be it. A lot of patients cleared with that, or you could repeat that treatment again a week later, and it wasn't really like a maintenance thing for these patients. But now maintenance dosing of this is approved actually, and so there is a sub-Q version that you can take every 4 weeks. So it's been a game changer for the few GPP patients that I've treated, and I can tell you from interacting with the residents over at EVMS, they see a fair bit of GPP and have used a good amount of this medication with good success. A nice safety profile. You worry a little bit about infections with the pathway, but not significantly so like we've worried in the past with cyclosporin and some of these old school immunosuppressives. So that's something really nice too. And then something to look forward to in the pipeline that's really exciting too. Again, talking about neutrophilic dermatoses, right, in this pathway is pyoderma gangrenosum, something that's still rare but a little bit more common than GPP. I see many cases a year of pyoderma gangrenosum, and I've used all sorts of things. Our TNF inhibitors, cyclosporin actually was a mainstay for me for quite a while. I've dabbled with some JAK inhibitors now. Those of you who know me know I use a lot of JAK inhibitors, and that's worked really well for my PG patients. But that's again a very severe disease that's not always easily fixable either. And so now I've had a handful of patients that I've treated off-label with spesolimab who've done really well with pyoderma gangrenosum, and it is something that is being studied as well. So hope this was helpful.